Good afternoon, everyone. Thank you so much for joining us today for Medicare Madness, presented by Marcia Mantell. My name is Jennifer Climo, one of the senior advisors here at Milestone Financial Planning. Marcia is a consumer advocate around Medicare who also offers healthcare consulting services to advisors and their clients. Thank you so much for being here, Marcia.
I am delighted, Jen, that you are offering this Medicare Madness update again. So thank you so much. I've got lots of news to share. So let me just pull up some slides. Welcome, everyone, hopefully from near and far. There's a lot going on in, as I call it, Medicare land these days. And hopefully the updates that we have for you will help you in your planning, not only for entering Medicare if you're not there yet, but if you're in Medicare, for the tactical moves you need to make this year. There is a lot happening. And, it's tongue in cheek that it's Medicare madness. You can decide at the end if you think it's madness or not. But, a word to the wise, the title's appropriate. All right. So what we're going to cover today, Medicare basics, and just to make sure we're all on the same page with Medicare and the changes coming for 2025. The most amount of time we'll spend today is the big changes happening in Part D plans, the prescription drug plans. Then we'll take a look at what's been happening with these Medicare Part C plans. And they're advertised as the Medicare Advantage plans. And then we'll talk about what you can do. And I'll leave you with some resources and additional information. If you have questions along the way, we'd love to answer them. If you could use the Q&A feature or the chat feature at the bottom of your Zoom screen, you might have to open the tray on the bottom. You'll be able to enter your questions there, and then Jennifer and I will get to them at the end. All right, you ready? Here's where we're going to start. For anyone who's new to Medicare, there'll be a lot of terminology and language out there. But what's most important for you to gather today and sort of think about for yourselves in the future is that Medicare comes in two flavors, and it's made up of multiple piece parts. So on the left, there's what I call the quartet. This is where you have four individual pieces and parts of Medicare. There's Part A that covers hospitalization. There's Part B that pays for your doctors and outpatient services. So two completely different purposes of Medicare, but you need both of them to start to build your comprehensive coverage. If you're in the quartet, you're also buying a Medigap plan or a supplemental or MedSup. It goes by many names. I call it Medigap because it's literally an insurance product that pays your share of the costs, because A and B aren't free and you still have to pay usage costs or a share of the costs. And we'll look at those costs for 24 and 25 in just a minute. And also, if you're in the quartet, you buy a standalone Part D plan, and this helps you pay for your prescription drugs. Now, the alternative or the substitute to the quartet is the trio. And this is a private insurance product that is offered in the marketplace, generally advertised as Medicare Advantage plans. But under the law, it's actually Medicare Part C. So to have a Part C plan, what you do initially is you enroll in Part A to get your hospitalization covered. You buy your Part B plan. So again, physicians and outpatient services can be covered. And then you turn all that over to an insurance company, to the Medicare Advantage HMO or the PPO, whomever you're working with. So you're assigning your benefits away. You get them. They're just coming for you and providing insurance in a very different cost structure and who's at the table. On the quartet side, there's you and your doctor. That's it. On the trio side, there's three of you at the table. There's you're still there. Your doctor, still there, but also the insurance company. And the insurance company is the one who's driving your actual final decisions on the care you're going to receive. So they're two very different avenues for getting your health insurance. Once you're in retirement or 65 and older, you get to choose. Also with the trio, you get your Part D is already wrapped into this Medicare Part C bundle. So you get C and D together in the trio. All right, so that's the table setting. Now, each part of Medicare is structured differently, has a different purpose, and you have different amounts you need to pay. So under Part A, The costs that are associated with this are not monthly premiums like you pay to your group health plan at work today. Instead, Part A costs are usage costs. It's only if you use the hospital. So you're an admitted patient into the hospital, you would have to pay the first $1,632 this calendar year. I'm estimating it'll be $1,680 for 2025. And that's based on, you see all the numbers in parentheses in pink. Those are my best estimates for what's coming for January. The numbers haven't been released yet. CMS has not released them, the Centers for Medicare and Medicaid Services. Should be any day now, but what we've got now, we know that costs always go up in healthcare, and the long-term rise in costs for Part A tend to be in the 3 to 4% range. So I rounded some numbers up, but it gives you an idea that if you go into the hospital when you have Medicare Part A, you owe the first $1,600 and more next year. If you then go to skilled nursing for your rehab, well, then you don't pay anything for the first 20 days, and then you pay a per day cost that you stay in nursing home care. After 100 days, you would pay all the costs. That's why Medicare is very specific, trying to shout from the rooftops that, hey, we don't cover long-term care here. This is before long-term care kicks in. But after 100 days in skilled nursing, you're on your own. So it's a planning opportunity, is what I like to call it. That's Part A. Part B pays your doctors again if you are getting cancer treatments, chemotherapy treatments. It's for any infusible drug, any osteoporosis drugs that are delivered in a clinic setting. Those are the outpatient kinds of services we're talking about. Now, Part B has always and forever been a cost-sharing premium kind of arrangement. So Medicare started back in 1966. That was the first year to get Part B premiums. And people then had to pay $3, which was a lot back then. I know we're looking at now, kind of, putting our nose up like $3. I mean, come on. But it has always been this premium arrangement where the consumer, the beneficiary, the Medicare person has to pay part of the overall premium. Well, as you look at this chart, you can see the rise in the premium cost, your share of the premium cost. We're at $174.70 this year. The trustees report estimated $185 per month, but that's a pretty high increase for Part B premiums. That's almost 6%. I'm guessing it's going to be 183. We'll see where it ends up, but it won't be 174.70. So we can anticipate a increase in your Part B premiums coming for January. So how much do you pay when you have Part B services? Well, you've got this monthly premium that you need to pay. I split the difference for this page. My 183, the trustees report 185, and says, all right, what if it's 184 per person per month coming in 2025? Well, you'll pay the $184 per person per month. Excuse me. And then when you see your doctor for the first time in the new year, we're all responsible for the Part B deductible, or the first dollars in. So this year it's $240. It's a one-time payment during the year. It's not a monthly thing. It's just once you go to the doctor, you're going to get billed for the first $250 is my estimate for 2025. So in all, we're looking at about $120 increase year over year in what you're paying for the premium. So just to get Part B. Once you have Part B, it only covers 80% of covered costs. So you would be on the hook for the other 20%. Now, if a doctor's appointment is short and it's just kind of a, non-critical visit, maybe it's $400, so you end up paying $80. Like, that's not that big a deal. The problem is if you're the one who has cancer or any other autoimmune or some type of chronic illness that requires these treatments, say every month, that run anywhere from $20,000 a month to $120,000 a month, you would be on the hook for 20% of that cost if you didn't have a Medigap plan in place, or if you didn't choose the trio. And then the pricing is very different over here, but your out-of-pocket expenses would be capped. either by the Medigap premium or by the Part C plan. So those are just things to keep in mind. Again, everything is expected to increase for 2025. Now, not everyone pays the Part B premium of $174.70. We call that the standard or the base premium. And again, what you can expect for 2025 is that all of the high income folks, I'll tell you the definition in a second, that they will have to not only pay more for their Part B premium, but it will be again in that 5 to 6% increase more. So what we're waiting for, and Jen and I were talking just before you all got on, it's like, where are the costs? Where are the new premiums? And especially for this chart, this is the IRMA chart. This is the income related monthly adjustment amount or means testing. So when you have high income in retirement, you will pay more for your Part B premium. And it's a statutory formula, and it's determined as soon as that base premium is calculated. So what people are paying this year, if you are above we call it the Medicare MAGI, Medicare Modified Adjusted Gross Income, which is your AGI from 2 years ago, your adjusted gross income on your 1040, plus any tax exempt interest. It's just a number. But if that number is higher than $206,000 and you are married filing jointly, or if that number is above $103,000 and you're a single filer, well, then you're going to pay more than the $174.70. And you can see the numbers going up. What this is doing, the reason that higher income people have to pay more is they're getting less of a federal subsidy. Because the premium isn't $174.70 per month. It's a number much larger than that. And so you're only paying a 25% share of the overall premium unless you have higher income. And then you're going to pay more than 25% will be your share, and the federal government will pay less. So anyway, we're waiting. This entire chart will be updated. Both the Medicare MAGI thresholds will increase. So instead of 206, I don't know, maybe we'll be at $210,000. We won't know until the new numbers come out. And then the premiums also will increase. Now, the wild card this year is what's going to happen with Part D IRMA. So the good news is most people don't have to pay anything for Part D drug plans to the federal government. You have to pay to the insurance company where you're buying your Part D plan. But most people do fall into the standard tier, that $174.70 plus zero. But if you're a high income earner, you're going to also pay a Part D IRMA, and you pay this to Medicare. So the numbers have been quite small up until this year. I'm kind of expecting, well, it depends on the day. I'm expecting these numbers will go up on a percentage basis much more significantly than they have, unless they're going to be capped at a 6% threshold. And I'm not sure. So we'll let you know. I know Jen has a blog that's ready to go out as soon as we get these numbers. I have a book ready to come out as soon as we get these numbers. But there's a lot of changes expected. So kind of brace yourself for this part of the Medicare madness. I just want to remind folks too, if you're just getting into Medicare and you have retired or your hours have gone down or you're getting a lot less income going forward, you can appeal those IRMA charges. These are the 8 reasons. It's a little form called the SSA 44. So you're not necessarily locked into higher income IRMAs if you can show that you have had a major life event that is changing your future income. And Social Security will work with you on that. So again, it's the SSA 44. It is an appeals opportunity. It's a very simple form to fill out. But you do have to have one of these 8 reasons why you're asking for a redetermination of your Part B premiums. All right. Part D. I spend an inordinate amount of time, like normal people shouldn't spend this much time looking at prescription drug costs, but that's what I do this time of year. So let me share what's going on. First and foremost, it's important to understand how the costs happen with Part D plans for all of us. So there come these three powerful factors are going to determine your individual drug cost. And everybody has a different drug cost. There's no average or mostly people do this or mostly people do that. It doesn't work that way. It is based in your zip code and the drugs you take and the pharmacy that you've chosen and the formulary. And the formulary is the list of drugs that every insurance company will cover, or the ones that aren't there, the drugs they're not covering. So it's putting these pieces together to figure out what your drug costs will be. The good news is Medicare.gov has an amazing tool. It's called the Plan Finder. They say Find Plans Now tool. And it puts all of these, it's a massive database, all these massive details together for all of us so that we simply load in our zip code and our drugs and the dosages, and you're going to get a report that shows you which drug company, drug insurer, is offering coverage for your drugs at a variety of pharmacies and how much it will be. And you're shopping for the cheapest combination of premium plus drug cost. It really comes down to that, drug X is exactly the same at WellCare as it is at Cigna, as it is at Express Scripts. It's the drug you take. There's nothing special if you get it from one versus another. What changes is the formulary, the pharmacy relationship to that insurer, and the cost of the drug. So let me show you some examples. Oh, let me first finish this. So what I want you to brace for in 2025 is that the number of plans offered in your zip code is likely going to be less. Overall, there's been a 26% decrease in standalone Part D plans year over year. It is a stunning decrease in the number of plans being offered. Now, in general, like we don't all have a 26% decrease, but across all the plans being offered, this is a marked reduction. So what's happening is, there's a consolidation starting to happen, or drug insurers just backing out of the market. So it's going to mean higher costs for us because there'll be fewer players in the playpen. The other big thing that can happen is that the drugs that you take, your prescriptions, I'm not talking anything over the counter, that it's not part of Part D plans. These are strictly the drugs that you need to stay healthy that have been prescribed by your doctor or another health professional. Dramatic cuts in the formularies. The sheer number of drugs, first of all, is amazing. It's many thousands of drugs out there. But the insurance companies can decide if they're going to cover every one of a drug in a category, and they don't. The covered drugs are down 19% since 2010. And at this point, only 50% of the drugs that are manufactured are covered on Part D formularies. And no two formularies are the same. So it's not like you can say, I've been doing a lot of research on insulin this particular month. So Humalog, which you'll see in a minute, Humalog is covered by everybody on all the formularies, but Trujeho isn't. It is not that simple. It is drug company by drug company by drug company, and then plan by plan by plan within that drug company. Most drug companies offer 2 or 3 variations on a theme. So they'll have like Value RX and then Premier RX and then some other name. They may or may not offer the same Humalog on all 3 formularies. It's completely up to the Part D insurer, and you won't know unless you go shopping on Medicare.gov's plan. The other big piece is the pharmacies. They need to be preferred in network pharmacies or just preferred in order for you to get the best price. If you end up in an out-of-network pharmacy, you're going to pay just a whole boatload more. And is CVS a preferred pharmacy this year with your Part D plan, or isn't it? Is your local pharmacy down the street that you love to go to, are they in network and preferred or not? You have to go shopping. So what I'll tell you, I'll just get right to the bottom line here. It's just gigantic changes in the number of plans and the premiums and the cost to you for the drugs that may or may not be on your formulary. So remember, again, most people don't pay any premium to Medicare unless they get hit with IRMA for the Part D access. But you pay a monthly premium to the private insurer. And this is where the game starts. It's how much are the insurance companies charging for premiums? And they've jumped a lot for a lot of people, unless you live in New Hampshire. And so this is a really funny little thing. In 2024, your premiums for the lowest cost plan were 50 cents per person per month. Yeah, literally 50 cents, like a 50-cent piece that you used to get from your grandparents. This year, your premiums have dropped down to zero. Like, okay. But the highest premium jumped quite a lot, from $121 per person per month to $156. You also lost 6 plans, from 20 down to 14. All right. Well, I know some of you may live in Massachusetts, which is where I'm from. So I looked at Plymouth County, which is where I'm sitting right now. Said, well, what's happening for the Massachusetts people in Part D plans? Well, last year, our lowest cost plan was also 50 cents. But look what happened for 2025. It went up a walloping like 2,500% to $12.40. This is the lowest cost plan. So if you take no drugs at all, you still need a Part D plan, and you're going to have to shell out $12.40 per month to be on a plan that you're not going to use. Or if you have 2 little generic drugs, you're going to pay $12.40 a month instead of 50 cents a month last year. The highest premiums also jumped by $35, and Massachusetts residents lost plans as well. Now, for those of you who are in Florida or wishing to go to Florida, well, you have a completely different structure of what happened. You had a $0 plan last year as your cheapest plan in the Part D land, and this year it stayed zero. But your highest plan premium went down, but you also lost 6 plans. So the reason I show you these 3, and we could pick any states and any counties and any zip codes, it's a complete crapshoot year to year. And so unless you're in the plan finder looking for you really do need to protect yourself. You'll be caught, and you cannot change after December 7th. If you don't do this now during open enrollment, you're stuck with whatever plan you picked in 2024, even though it might not cover your drugs and it might not be the cheapest plan you can get. So here's a look. Now I loaded into this is part of the plan finder's output. I went into New Hampshire in Manchester County, Manchester and Belknap County. And the cheapest plan that you have available for 2 generic blood pressure medications, I have a basket of drugs that I track every year. $0 monthly premium for WellCare Value Script. Only this one plan has a $0 monthly premium. And look at this, you'll pay nothing at the pharmacy or mail order, because these 2 generics in New Hampshire at the zip code happen to be 0. But if you don't pay attention to the pharmacy, you're not going to pay 0. If you normally go to Elliott Pharmacy at River's Edge, wherever that might be, you're going to pay for these generic drugs that should be 0. You're going to pay $171 because, oops, you didn't check your pharmacies. Or if you're at, what is this? Concentra, Manchester. It's an out-of-network pharmacy, and you will pay $568 if you don't do your shopping. It is a big deal. Now, what about if you're here in Plymouth County? So we're 2 hours south of, Manchester, maybe 3 in Plymouth. Costs are very different for these drugs. So again, we start with not a $0 monthly premium, but $12.40. And our total cost is $148 between the premium and the drugs. The drugs happen to be 0 as well. So you're just paying the monthly premium. Oh, unless you don't shop for your pharmacy. So you only get that $148 if you're at mail order, Walgreens or CVS. But if you're out of network at this High Point pharmacy, $717. $700 for 2 free generic drugs, or $320 if it's just an in-network. I just cannot stress enough how important it is to go into this plan finder every year for everyone. It is not hard. It's annoying. It's time consuming, but to save 700 bucks, heck, I'd do this to save 50 cents, to be honest. But, it just depends where you are in your budgeting process. All right, Florida residents, you look like New Hampshire, right? $0 for your WellCare value script is the cheapest, $0 for your plans. But here's the look at the 6 little New England states, right? We are this tiny little region of the country. And last year, reading from left to right, last year, you see the New England states listed and just the random zip code that I picked in each of these. Everyone had a 50-cent monthly premium, or you paid $6 a year for your plan. In 2025, I literally wrote an article and I said, what's with New Hampshire and Maine? What did they do so nicely to WellCare that you get a $0 monthly premium and the other states around you are at $12.40? Like, hey, what do we do here in Massachusetts, Connecticut, Rhode Island, and Vermont? Well, I don't know what we did, but these are the lowest cost premiums in our 6 New England states, which just on the surface, you look at this and you go, this is nutty. It is. I can't tell you why. I actually have no idea. Other than to say that it's the business. All these insurers are a business. They all need to run at a profit. I get that. But this just, like, it doesn't pass the smell test. But if you live in New Hampshire, yay for you. There are a couple of other strange situations, just to know it's not only our region. But on the West Coast, it's also crazy. So WellCare was the cheap plan last year for California at 40 cents per month premium, not the 50 cents we had. They were 40 cents. But this year, WellCare is the second lowest plan. They won't know that again if they don't shop. So they'd have to cough up $208 just in premiums if they don't shop. Or if they do shop, they're going to see that Cigna Healthcare Assurance came up as the cheapest at $1.80 and pay only $21. New York and New Jersey are maybe my favorites this year. They sort of win for me. And you know how New Jersey is always the brunt of many jokes, especially from the New Yorkers. Well, last year, New Jersey paid $0 for their monthly premiums, and the New Yorkers had to pay $44. Well, this year, New York is getting hammered. I don't know what they did to make people at WellCare unhappy, but their premium jumped almost 1,000%. So they're paying $464 versus $27 in New Jersey. So the New Jersey, on the other side of the Lincoln Tunnel, they're feeling pretty smug right now. Now, let me also just caution you, this will not necessarily be your prices. You might not have drugs that fit into the formulary at these low premiums. These are just the lowest premium plans for 2 generic medications. It doesn't have to be blood pressure meds. Usually it's most generic. So whether it's the generic of Lipitor or the generic of any other drug, they tend to fall in the $0 to about $5 and are in the lowest premium plan. But not always. So let's keep going on Part D plans, because we now also have, on top of all of these shenanigans, the Inflation Reduction Act of 2022 is in full swing. So this is the gigantic law that set into motion really important changes to Part D plans. And the goal overall was to reduce out-of-pocket costs for seniors. This is a noble goal. I will also say it's extraordinarily difficult to execute in this complicated drug environment between manufacturers and insurers and formularies and premiums and Medicare, the federal government involved and such. But what we have to recognize is that there were between the estimates were 5 to 6 million seniors had been paying more than $10,000 a year just for their prescriptions. Like, that's an insane number when you're 89 years old. But some seniors, a lot of them, are in this boat. Others paid $3,500 or $5,000 or $8,000. I mean, it's a lot of money to stay healthy. The Inflation Reduction Act did 3 major things. First, it finally allows Medicare to negotiate drug prices with the manufacturers, which by law had never been allowed since the beginning of the Part D plans back in 2003 when the Medicare Modernization Act happened and Part D plans were introduced. It also capped insulin. All insulin products are capped in all Part D plans at $35 or less. And that went into full effect. It was tested for a few years. It went into full effect last year. So if you are dealing with diabetes, your product should be $35 or less per month. Put an asterisk on that. And then this year, well, 2025, the total out-of-pocket cost for RXs should be capped at $2,000 a year per person. Your premiums are additional. So this is where I start my analysis this year. I'm thinking this is really going to be great for a lot of people. Now, a lot of people are going to get a lot higher premiums, but it's not going to break the bank. And a lot of seniors should really benefit from the $2,000 cap and a $35 insulin cap. So I run my very first analysis for a client of mine in the Boston area. And this is what I see. You get a top line summary first. So the cheapest plan in this zip code was WellCare. There's the $12.40 premium. And I look over to see the $2,000 cap and I see $5,000. Like, what? I know I didn't pick all out of network pharmacies because I picked CVS, mail order, and Walgreens. Those are the three you always want to shop first and then add two others. And I'm looking at this and I go, what on earth did I do wrong? So you drill down a bit and look into the details. And what I had entered, this is Norfolk County, Mass, so just west of Boston, put in 2 generic insulin drugs. They're not capped. The drug costs were not capped at $2,000. And one of the insulins was not capped at $35. And I'm shaking my head going, what the heck? Here's the big lesson, and I forget this from time to time, and we cannot forget this key word. The key word is covered. It's super important in Medicare land to remember all the words and to remember to use them. It's not that drug costs are capped at $2,000 per year per person. It's that covered drug costs are capped at $2,000. And it's not that all insulin products are capped at $35 a month. It's that all covered on that Part D formulary are capped at 35 bucks. So what you see here, this is again an insulin person prescribed. These are 2 real drugs prescribed to a real person. They're the generic versions. So this insulin glargine is $420, about $35 a month at CVS and Walgreens, skip over Union and mail order. So this gets the cap. But if this person goes to an out-of-network pharmacy, they'll pay the full retail price of almost $5,000. Oh, that's part of the problem. And what you see, this insulin Lispro was not covered, meaning literally not on WellCare's formulary. WellCare is not covering in this zip code this coming year insulin Lispro, a generic insulin drug. No, I don't know why. Because they don't have to. So you pay the full retail price. And that's why we have to be shopping, because what we hear and what we assume are not how these laws are applied to individual people. So then I was mad and I went to the formulary. It is 100 pages long and it is page after page after page of the drugs that WellCare value script covers. And what I find instead is that I didn't continue in WellCare. I went to all the formularies, to be honest. I pulled up Cigna Healthcare Saver, and what I found was they cover the 2 brand insulins that are the brands to these 2 generics. So Humalog, I think, is the Glargine, and Trejeho is the Lispro, or I've mixed them up. But nevertheless, the 2 brand names at Cigna, $28 premium, not a $12 per month premium, but they are capped at $35 because they are covered drugs on the formulary. But if this person thought they were going to use Andrew's pharmacy, they would pay $16,000. So you can pay $840 for the drug, or you can pay $16,000. Really, it's your choice. All right, so that's the drama going on with Part D plans. But then I said, oh, but okay, we can help people get through that. Let's make sure they also know they can now spread their payments, whether it's capped at $2,000 or if it's $732, we can spread them out over this new prescription payment plan. It's like, thank goodness. We can finally, and this again is part of the Inflation Reduction Act, seniors can now smooth out their payments. Because what happens with the payments, you have the first deductible, it's $590 this year, 2025. You have to pay the first $590, and then you'll pay portions of costs, and then you pay less. So you have this big front-loaded cost. And so it's like, oh, good, we're finally going to get to smooth this out. It's not that simple. It's not like you take the cost of your RXs, which we now know, and divide by 12, which is what any normal payment plan would be like. You know, I don't know, your mortgage, like your car payment. It's more like credit card payments. So instead, each month will be recalculated. And it's literally, this is from Medicare, it's what you would have paid for any prescription drugs for that month, plus the previous month's balance divided by the number of months left in the year. Once you get that, and again, only for covered drugs and only for in-network pharmacies or preferred pharmacies, then you'll have your cost of your drugs. You add your premium on top of that. Here's what it looks like in the real world. And it just gives me a headache. So here's a mail order situation. They literally do this on Medicare.gov's Plan Finder tool. So you don't have to do the math. This is what they're showing you. So 12 months in the year, here's someone who used mail order pharmacy, and their grand total of their cost of drugs, of covered drugs, was $1,753. So highlighted in yellow, if you did not use the payment plan, the super groovy formula, you'd pay $752 in January plus premiums. Then you'd pay $369 in April and $369 in July and $261 in October. With mail order, you get 3 month supplies. All right, so again, front loaded, you got to cough up $750 in January, right? So with the payment plan, I'm very excited about this payment plan. It's like, oh, excellent, $166 only in January, and then 53 in February and March, and then 94 for the second quarter, $156 a month in the third quarter, and then 243 in the fourth quarter. What the heck? So instead of how I say normal people would look at a payment plan, just take $1,753 and divide it by 12 to pay your $146 per month so you can manage your budget, which was originally the goal of having a payment plan. This is just a mess. Like, who would do this? This helps you not one lick. Oh, wait, maybe the problem is mail order. Let me look at if you went to CVS. Yeah, you know, it's no different. Now you're paying monthly, so you pay $400 in January and $255 in February, and then you get down to $151 for a bunch of months until you reach some threshold. Then it's $49 in November and $0. And it's a higher number because while CVS is still a preferred pharmacy, they can charge different amounts than the mail order company, which they did. So with the payment option, you pay $166 instead of $404. That's good, all right, in January. And then it's 44, and then it's 59, and then 76, 95, again, blah, 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 November and December at 285. I don't know. I'd like to know if anyone finds this helpful. I certainly do not at this moment. All right, moving on. If that isn't exciting enough, and that Part D plans are the biggest mystery and mess for 2025. Please shop your plans. I'll show you how as soon as we do Medicare Part C plans. All right, just to remind you what these Part C plans are, these are a substitute. You are literally substituting Medicare, the quartet, with the trio. And you still have to enroll in A and B and pay your Part B premium and any IRMA, B and D. You're going to pick a Part C plan with a prescription drug plan, because otherwise you're going to run into penalties later. And the Part C plans, they typically operate within a local network. And that's how you get the best, meaning lowest cost that you can possibly get in the HMO network. The monthly premiums are low, and that is a positive marketing key message. They're zero in a lot of the plans, but you have to pay along the way. You're going to pay for the first 5 or 6 or 7 days that you're in the hospital. You're going to pay every time you see your doctor, except for your preventive visit. You'll pay, it might be $20, it might be $40. You pay, I don't know, $25 for an x-ray. You pay $130 for an MRI. It's this nickel and dime throughout the year. There are caps on how much you can be exposed to in the Medicare Part C plans. The out-of-pocket maximum in 2024 is $8,850, and in-network, $8,850. But if you are out of network, you'll pay over $13,000. That's the maximum a plan can charge. They can go less than that, but this is the federal maximum. In 2025, we see a big jump, $500 jump in the in-network up to $9,350 and $14,000 for out-of-network. It's a lot. On top of that, Medicare Advantage plans, Part C plans, can close up shop. They can just shut down the operation and no longer offer the Medicare Part C plan that you picked anytime they choose. It doesn't happen often, but going into 2025, we just have this bevy of plans that are shuttering because, again, with the Part D plans, putting a cap on how much consumers are paying, the companies are trying to figure out their revenue and their profit stream. So they're shutting down areas of the country or plans that they've deemed to be not as profitable. And it's with the biggest players. So Humana will stop offering MA as Medicare Advantage in this sentence, not Massachusetts. So Humana will stop offering their Medicare Advantage plans in 13 counties that will and has left over 500,000 seniors with no health insurance starting January 1. They have to get on and get moving to find a new plan right away. That's fine. You know, if you're sitting here on a webinar, you think, yeah, I can handle that. I'm 63, I'm 65, I'm 70. Can you do this at 85 and 95? This is just where I could tear my hair out. Cigna, also a huge player. They're exiting Medicare Advantage markets or reducing service areas in 8 states. It's only about 5,400 members. Like only 5,000 seniors. Okay, it's a lot less than 560,000. But I mean, come on, what are these seniors supposed to be doing? And CVS Aetna has announced it's planning to lose about 10% of its 4.2 million Medicare Advantage beneficiaries or customers. And the cuts are going to come across lots of states. The most specific one I could find right now in our area is Vermont, where MVP Healthcare and the University of Vermont Health shuttered their joint Advantage plan starting in 2025. So any of this can happen at any time. Medigap plans cannot just shut down. It would be like shutting down the insurance company. So Medigap, while it does come with a more expensive monthly premium, you have none of this when you're 85 and 90. And I've had several calls this October from people. I had a gentleman called from California a couple of weeks ago and said, I'm in a problem. I have a problem. I'm 86. I'm losing my Medicare Advantage plan. What am I supposed to do? Like, I have no idea. You know, if you're 86, you've been in Medicare for 20 years. Medicare Advantage plans didn't exist when you came in to the party. Part D plans didn't exist. So I find this to be mean. Personal opinion, not professional opinion. The other piece with this turning off or this idea of switching plans, which you hear on ads all the time. You just cannot switch from a Medicare Advantage to a Medigap plan in most states and in most cases. All right, there is no what's called continuous open enrollment in New Hampshire or Florida or about 42 other states. You can switch from a Medicare Advantage back to just original A and B Medicare and still buy a Medigap plan if you live in Massachusetts, Connecticut, Maine, and New York. There are a few other states that open the door on particular points in time. Like after you've been in a plan for 5 years, you can possibly switch. So there's some playing at the state level, but mostly people cannot switch. So you only get to choose a Medigap if that's the quartet you're going with when you first enter Medicare. So you have to be 65 or older, and you are starting your Part B for the first time. You get a one-time and one-time only 6-month open window to buy any Medigap plan that you want. No questions asked. If you want an Aetna Medigap, if you want a Blue Cross Medigap, you just call them up or put the application in online and it's yours. And then you pay the monthly premium and don't ever let that monthly premium lapse. So if you want a Medigap plan later in retirement, you're going to be subject to medical underwriting. And what they're going to find is the people who want to switch out of Medicare Advantage plans when they're 85 are those who are sick and they have some major health issues and they want maximum flexibility. You're not going to get a plan. By and large, you'll be denied the plan. You may be accepted if you're younger, but you'll be charged a higher premium, or you must wait 6 months before that plan, the new Medigap, would cover your chronic issue or your health shock that you're trying to deal with. In addition, I just wanted to make a note here that you want to be careful that with certain Medigap plans, if you're trying to buy one with a lower premium, your doctors in New Hampshire and Florida and most other states can charge what are called excess charges. And they can charge up to 15% higher than the Medicare rate. Medicare sets all the rates, and not everyone likes those rates. I blame them. So they can charge higher amounts. You would have to pay that. Just a little note I didn't want to forget. So here, where's the good news? Well, the good news is coming from Congress, if you can believe it. Congress is very aware that seniors are very unhappy with a lot of these behaviors going on with the insurance companies who sell Medicare Advantage, Part C plans. They're also the same insurers who sell Medigap plans, by the way. There's not two different lanes for the sellers of these products. So Congress cracked down in a big way this year with the advertising rules, and they become much stricter. Now, you may recognize Martha and Joe from last year's commercials. You won't see them so much this year, if at all. I've not seen Martha show up, and I watch a lot of TV. Martha has not graced my television screen. The ads are kinder and gentler, as I call it, and they're more accurate. A lot of technical terms still, and the big footnote, it's, 3 inches tall, but in 2-point type. We can't read it anyway, but they got a big hand slap, the insurance companies. There's more balance. You see some Medicare Advantage ads, lost my train of thought there for a second, Part C ads and Medigap ads this year in a much more equal measure, not just 99% Medicare Advantage screaming at you ads and an occasional Medigap ad. But where Congress hasn't cracked down yet is there's still no parity in commission. So let's be really clear. Why Medicare Advantage is pushed so heavily is because the brokers or the agents who sell these get 3 times more in commission than to sell a Medigap plan. Well, we would all do the same thing. We have to feed our families. So some progress, surprisingly. The other thing that's really interesting is the name Medicare Advantage is really a discredit to seniors, trying to fool them into thinking they're getting Medicare and that there's some advantages. No and no. So the House, a couple of Congress people proposed the Save Medicare Act. Now, I don't know if this is going to go anywhere, but the fact of the matter is it got as far as having a bill not on the floor, it's earlier in the process, but it is a proposal. There's the word. And what they proposed is that the bill would require Medicare Advantage to rename its products. And they're proposing, they call it alternative private health plan. It's not a snappy name, but just interesting that Congress is more than fairly aware of this problem with the ways these plans are advertised and frankly in the way they are handled and the denials of claims and the prior authorizations and all the bad stuff that does go with this particular kind of plan. Not to say there isn't bad behavior for everyone, but this has risen to the top. So I just wanted to let you know that. All right, let's talk about what you can do now during OEP is open enrollment period. This time of the year, oh, here I can go to the next slide, which is October 15th to December 7th, is Medicare's open enrollment period. It happens the same time every year. I use November 1st as the anchor date. Conveniently, it's this Friday, as the day to reshop your plans. This is what every person on Medicare needs to do. And if you're not yet on Medicare, I'd suggest load your drugs in now, get a benchmark. Like if you were entering Medicare in January, how much would it cost to cover your drugs that you take already that you know? It is a fascinating exercise. But if you're already in Medicare, you really have to do this. You're reshopping your Part D plan and your Medicare Advantage plan. And the Medicare Advantage plan that you're reshopping is based on not only the drugs that you're taking, but also are your doctors even staying in the network for next year? Are your hospitals that you prefer to go to staying in the network? Are your specialists in the network? You have to check for not only drugs, but also your entire care network. What's changing? I call the behind the scenes activities change pricing every year. The other thing to note is December 7th really is the deadline. Whatever you have changed, whatever plan you've bought in this 7-week period, the last one on record is your final answer, and you're stuck now with that plan for the full 12 months of 2025. These are 1-year contracts, and you cannot enter them any other time of the year if you're already in Medicare. So the steps that I recommend, you can, pick the dates that work for you, so long as it's before December 7th. In November, I check all my RXs, my prescriptions, and update any changes to those drugs in your My Medicare account that hopefully you've set up if you're already in Medicare. And November 1st is the big day. I don't like having 7 weeks. I like it. On the one hand, it's good that we have a range, but I think people need to just mark their calendars, use the Medicare Plan Finder to review those drugs like what I showed you earlier. And if you have a Medicare Advantage plan today, you need to review the website, the ANOC, the annual notice of change, the explanation of benefits, everything that's come to you in the mail about the plan you chose for this calendar year. You need to review to see if it will work and if you want to continue it for next calendar year. And please double check your prescriptions. That is the most important thing you can do because as you saw, they have to be covered on the formulary. And what was covered last year does not need to be covered this year. That is not the contract. We have a 2024 contract, then we can do whatever we want for 2025, and it's to the consumer to figure it out. November 1st, you'll fill out your application or call the Part D insurer to buy a new plan. If you're buying a new plan, confirm the pricing that you found on Medicare.gov. Make sure you know what you're anticipating for January. And then in early December to mid-December, you'll get your determination letter from Social Security. So here, just as more of a reminder, check your Part B premiums to make sure you see what the new numbers are for you and know what your new Social Security benefit will be for 2025, and then decide if you qualify for an appeal. On January 1st, this is the start of that new plan year. So whatever you had in the system on record for your Part D or Medicare Advantage, that's now in effect for the next 12 months. So then also, if you made a change, make sure you contact your doctors or specialist or who's ever prescribing your drugs to make sure they have the new plan information. All right, I'm excited for your questions, so make sure you're entering those. I can't see anything while I present this, so use your chat or Q&A section, because this is our last section together. Here's where you go to shop your plans and reshop your plans every year. It is Medicare.gov. Make sure it is .gov. There's a Medicare.com site out there, and it is a retail insurance group that is selling you stuff. Don't go to that one, Medicare.gov. This is where you see the entire universe available to you for the drugs that you take and the pharmacies that you're looking at in your area. I'm a big spreadsheet fan, so make a spreadsheet, compare some things that you want to look at, and then contact whichever new insurance company where you might want to or do want to start your plan for 2025. So it's a click, it's put in your zip code if you don't have a Medicare number already, and put in your drugs. It is that simple, but it's more than that. You have to pick the pharmacies. You can go back and forth. You can download PDFs so you can compare things on the kitchen table. It's a lot, but it is definitely doable. Oh, and I even showed you, it's easy to run your individual numbers. So here's once you click on Find Plans here, where the arrow is, this is the next page you see. So if you have an account already, you're going to go in using your account number, and you have to be in Medicare already before you can set up a My Medicare individual online account. Otherwise, you continue without logging in. Coverage period is 2025. Put in your zip code. Hit continue. You'll answer a question if you have any extra help plans that you use, and otherwise start putting in your drugs and see what the results are. Another really good option is Ship Resources. This is a free resource that all of us have in every state. It's required by law. It's an army of volunteers who know the plans in your local area really well. You find your particular group by going to shiphelp.org. SHIP, and it stands for State Health Insurance Assistance Program. I know, I don't know why they had the A in there either, but nevertheless, there are different SHIP organizations in each state. In Massachusetts, when you click on shiphelp.org and then Massachusetts, you'll see that SHIP is called Shine here. In New Hampshire, SHIP is SHIP. And in Florida, SHIP is also Shine, but it means something slightly different than in Massachusetts. So again, every state can do what they want, but they have to provide this free resource. Getting an appointment this time of year is really tough because it's open enrollment, but any other time during the year, they will meet with you generally at your local senior center or at the library. And read. Keep up with this stuff. There's a lot going on. This is Retirement Daily on the Street. I contribute an article generally every month. This one, the Part D Premium Skyrocket, is one of my articles, and Get Ready for Medicare's Open Enrollment. Bob Powell is the editor of Retirement Daily, and he has an entire section on Medicare and Social Security, and it's got updates daily. So find some good resource that you can go to and just keep track of what's going on. These laws are going to continue to change. It's just a highly intense year going into 2025, and there is much ado about a lot. So with that, let me say thank you so much to all of you who have stuck with the program so far. Jen, thank you to Milestone Financial Planning for inviting me back this year. You all can follow me on Boomer Retirement Briefs, my long-running blog. I'm an author and blogger, and absolutely happy to help Jen and her team out if you have questions. So I look forward to hearing from you all.
Thank you so much. This was very, very helpful. We do
good.
have a couple of questions. I don't know if you can see any, but I think we should start with the most recent one. I'll just read it so everyone can see what it is. We have somebody who's turning 65 in May. So how will that impact their ability to sign up for Medicare? Should they look now, wait later? What should they do?
Excellent question. Yeah, so if you're turning 65 and you need to be on Medicare, the month you turn 65, so May of 2025, you should absolutely look now, because this is the only time of year where you can see the full 12 months of these drug plans, the pricing. What happens is every month that goes by, the drug companies can only sell you the plan that starts the first day of the following month. So if you look today, where we end of October, they have to start your drug plan November 1st. And you would only see November and December. So you get a 2 month, and it really fools people. So for someone entering full on Medicare on May 1st, you would normally shop 3 months in advance. So April, March, February 1st, you'll apply for A and B, and you might start shopping around then. But you now will only see March forward. You'll get, 10 months of the years. So you can't budget well. So I would go in right now, I would lock in the full 12-month 2025, just so you know. And then when it is actually time for you to enroll in Medicare, you'll have a foundation. You say, oh, okay, here's how it's starting to work. So anyway, that's my 2 cents. I think it's a great idea for you to shop now. And then you don't actually buy a plan until first week in April, and it will be effective May 1st for you.
Great. Now, what if they take minimal medication? Do they have to subscribe to Part D?
Yeah. I've written a fair amount about this. So everyone's going to have their own opinion on the penalty. So the situation is, if you do not get into a Part D plan on time, and there's some different on times depending if you're covered by a creditable plan at your employer or your spouse's employer. But let's say whenever you get in to A and B, you also need to have Medigap and D all start the same time, even if you don't take any drugs today. So here's my big caution. So, by the way, everyone hates that. Duly noted. If you do not get in on time, because you are healthy and you're not taking anything, and frankly, if you needed something, you just go to CVS and buy it with Good RX. All totally true. Except there's this 1% per month penalty on Part D plans. So, and you can only get in once you miss your window, you can only get in during open enrollment. So you will go 12 months without a Part D plan. So you start out with a 12% hit. All right, it's on $35. It's not that big a number, but it lasts your entire retirement. So the analysis I did, I came up with, and I forget what all my assumptions were, to be honest, but it's $18,000 over a 25-year retirement that you could have spent on your grandkids or on having fun. So we tend to think of these things in really short, like, it's only $3 a month. It's not that big a deal. It is a big deal on a cumulative basis over 25 or 30 years. The call I got a few weeks ago, a panic call from a daughter whose dad didn't have a Part D plan. He's 90, so he's been in Medicare for 25 years. 25 years times 12 months times the monthly premium came out to somewhere in the $100 a month penalty. Now, okay, dad's not going to live for another 30 years. So use that as a cautionary tale, either side. Either say, I'd rather risk it and pay. And he needed some very expensive drugs. That's what they were calling it that time, a couple of weeks ago. I don't advise it, though it was a whole lot easier to advise when it was 50 cents a month. It's like, I got 50 cents a month to throw away and don't take any drugs. But I'll tell you, if you only knew how healthy you will be tomorrow, let alone 3 years from now and 5 years from now and 20 years from now, we can't know. And that's what insurance is for. So
Right.
my feeling is, if you can afford it, just do it. If you live
There's
in
risk mitigation.
Massachusetts, it's easier because you can switch, you might start with Medicare Advantage, knowing that you don't want a network, and then you'll switch in a few years. It's harder if you're in New Hampshire or Florida.
So if you're in New Hampshire, then would it make sense to be conservative just to protect yourself against future medications that you might be on, because you don't know today what's going to happen in
Absolutely.
the
You have
future.
the zero, right? The zero monthly premium. You will pay nothing, but you've checked the box that I
And you
have
won't
my
be
plan.
subject to the penalty. And then you just sign up for a
Right.
cheap plan and let it go.
Yep.
Another question came in, which is, and then we get this one a lot, somebody who's working and
Mhm.
covered by their employer health plan, and they have an HSA. And so,
Mm.
and they want to know, should they sign up for Medicare Part A just to get in the system? But obviously that affects their HSA. What should they do?
Yes, you should talk to Jen. You have to be really careful, and this is going to be a long answer, but not that long. You have to know when to stop the HSA. So if you wanted to start your Part A, you're working for a big company, otherwise everything is covered by the company plan, and you keep enrolling in that company plan. You don't have to sign up for anything. You can work until you're 99 on that group plan. The employer has to cover you. But you really want Part A just because you feel you should have it. Okay, great. If you are applying on your 65th birthday month, you need to stop HSA contributions the month before your birthday month. If you're applying, say, 3 months before your 65th birthday month, you're applying 3 months after your 65th birthday month because it just works out. And that's when you're, oh, I meant to sign up for Part A. You needed to have stopped your HSA contributions the month before your 65th birthday month. If you are waiting until 70 because you want to maximize Social Security and you're still working, you're going to apply for your Social Security benefit so you don't leave money on the table 3 months before you turn 70. Well, that little move that you made automatically turned on your Part A Medicare. You don't know this, it's just you're magically supposed to know it. And now you needed to have known that so you could have stopped your HSA contributions 6 months before you applied for Social Security. So to say this is complicated, and the reason for all these shenanigans is because the two laws never coordinated the situation, which often happens with laws. We've had the Medicare law out forever, but when HSAs were introduced only 20 years ago, they didn't coordinate with Medicare Act. And Congress has not gotten around to it. They know this, it's not to be, they can't be bothered. So what happens is you are not allowed to contribute to an HSA at any point when you have any part of Medicare turned on. In reality, we're only talking about Part A for exactly this reason, Jen. You're exactly right. People think they should have it because it's no cost to them, but it does dramatically change your HSA situation. So you need to think about this a year in advance of turning on Part A. Is my best advice. You can't just willy-nilly do this stuff because then you have to call your employer and tell them, oh crap, I've been making ineligible contributions. You need to back those out, put them back into my paycheck so that I can be taxed on them because I wasn't eligible to have them pulled out of my income. Pay tax on it, get the correct W-2 at the end of the year. You cannot cross tax years without getting into a penalty zone. Now you're filing extra forms with the IRS and you're paying a small penalty and you still had to pull the money, you declare it as income. So it's a big mess if you mess this up.
So we've actually seen this in tax prep quite a bit. And when we're doing tax prep, we can, after the fact, pull the amount out of the HSA as long as we do it before the filing date. But because sometimes people don't exactly know when to file and when not to. But the basic rule is, and I just want to confirm and restate what you said, which is if you're applying at 65, you really just have to look at the previous month of stopping your HSA. If you're applying after 65, you have to go back 6 months, but not before age 65. 65 is
Correct.
the base.
And you go 6 months back from the application date. Where people get messed up is I'm going to
Right.
retire at the end of the year. So they
Right.
have they know their retirement date. It's like, oh, I just have to stop at the end of June because I'm going to retire in December. No, if you're going to retire in December, you're doing stuff in October. So it's 6 months back from October. So it's really the 9-month rule. I do
That
have
is
a
a really
series.
important point.
It really is, because this just trips up more and more people. So I have a series of 3 HSA articles I wrote last year, 2023, on Retirement Daily. So you can find them. They're all there, that covers these with examples and the tax forms that are used. And I mean, people just really have a tough time with this. And why wouldn't they? Nobody knows this rule.
Right.
So
It's super complex.
yes.
Excellent. Okay. And there are no penalties for somebody who is an HSA, has an HSA, and if they wait till 70 to retire and then they go on Medicare after they retire, there are no penalties for them because that's not considered late because they were covered by an employer-sponsored health plan. Just want to
So long as the
reiterate that.
employer has 20 or more employees. So I get
Correct.
this question a lot. People who had big jobs, right? They leave corporate America and they hang up their own shingle. And maybe 2 or 3 of them are working together. It's just them. Well, that would be a small company. In that case, you must be in Medicare A and B before the month of your 65th birthday so that it triggers on the first day of the month of your 65th birthday. So again, there's these crazy rules. The first day of the month birthday rule is another one of my personal favorites. You can never just tell me if you work with me, Jen, with your clients, you can't say you have a May birthday. Like the question I really should have asked, is it May 1st or another day, right? Because if you have a May 1st birthday, your first day of Medicare is actually April 1st because you technically attained the age of 65 on April 30th. If you can believe this is what our Congress does in writing the laws. That is one of my favorites.
Excellent. There are 2 brief other just comments. Oh, let's see. Is the Part D donut hole gone in 25 as there is a $2,000 cap?
Yes. Yeah, it's actually been gone for quite a while, but yeah, it's really gone.
Except it's not really gone. It's only gone if the drugs are covered. And it sounds like a lot of drugs, even generics, are no longer covered or maybe weren't covered before. I'm not sure.
Yes, but then you just pay the full retail price.
Right. But gross. That's a lot.
It's a lot. Isn't that stunning? Those numbers?
It is stunning. Yes.
I really just can't even stand it. Yeah.
It's shocking that a generic insulin drug would not be covered.
And you think that's the one. So what it makes me think is there must be, and again, we don't see any of these backroom deals. There's something else going on between the manufacturer of the brand names and the insurers, and the insurers will get more by having the brand name covered. Now, I don't know this, so really truly speculation.
We're speculating.
Yeah, but there's something else that, like, why wouldn't a generic be covered? You would think the brand wouldn't be covered.
Right, exactly. So we have to wrap up shortly, but speaking of speculation, are we speculating? One of the other questioners was asking that politics is what's delaying the release of the 2025 numbers that we're all waiting for.
Yeah, I think everything in this particular very short time period in our world history is politically, influenced. So I think that's why I'm really nervous about the Part D IRMA. I'm not sure what's going to happen with that. So I think it's going to be a bigger jump. And they've been trying to figure out, CMS, Medicare, the federal government, trying to figure out how to cushion that. And yeah, with any news will be made into bad news. So
that's for sure.
If I had my crystal ball, I'd say 11/6 is when we're going to get our Part B numbers. Jen, you can get that blog out.
All right, and we'll post the blog that week. Okay, another speculation question is if Medicare Advantage is canceled, do you think that might open the door for open enrollment into a Medigap policy, moving from a Medicare Advantage to a Medigap policy in states that don't allow it, which is most of them?
Yes, that is not even speculation. That is actually the law. When a plan is canceled on you, so not you deciding you want something different, but the plan literally closed up shop, it does open a 60-day and only 60-day window with a guarantee issue where you can buy anything available in your zip code, including Medigaps.
Great. So, that's good news.
That is good news.
Excellent. Well, I think we've covered all the questions here. I just want to say thank you so much. This is extremely informative. This video will be posted on the Milestone website for those of you that want to go back and watch it or share it with your friends. And thank you again.
Thanks, Jen. It was great to be here again. I really appreciate it.
Great to have you. Take care, everybody.